Welcome and good morning to all the girls and boys in Toyland. We're ready for a Medicare Jubilee today as we talk about what's going on or what CMS is proposing for plan year 2025 in the proposed rule. A good time of year for this session, because the rule was published in November, but also because comments on that rule are due in early January. We'll talk about that then. And we want to give you a quick rundown of everything that's in that rule, or at least some of the highlights in that rule, so that you can issue comments on the parts, especially around agent broker compensation, which you might be interested in here today. So that's kind of where we want to go today. Give you a tour of the rules, show you how to tell Uncle Sam what you think about this, and we'll get going from there. My name is Randy Lober, Learning Development Specialist here at Action Benefits, and I'll be taking you through the majority of today's conversation, but I am joined by my colleague, Chelsea Smith. Chelsea, say hi to the people, please.
Hi, everyone. Thank you for joining us here today and talking about some of these new proposed rules for Medicare. I will be in the chat answering any questions you might have. So anytime you have a question, don't be shy. Just throw it on in the chat and I will answer you in the order of which those questions are received. So thank you very much. And Randy, go ahead and feel free to take it away.
All right, I am taking it, and we are off to the races here. So let's talk about what's new in CMS's proposed rule for Medicare. There are 4 big categories that CMS is proposing rules on, or adjustments to how Medicare Advantage and Part D plans work. So we're going to look at access to care and some new ways that CMS is improving access to care, or would like to improve access to care in a variety of programs. We'll take a look at what CMS is proposing around supplemental benefits and how that might impact both your business and what carriers need to do throughout the year as well. We'll spend a little bit of time with CMS and how they're addressing some D-SNP updates, especially if you're working in that market. You'll want to have your pencil sharp for that. And we'll close today with I'm not going to say it's a lengthy conversation, but we'll close the day with a conversation around agent broker compensation and show you how to submit comments with CMS so you can make your voice heard based on how you feel about all of these things or any of these things going forward. So if that's what we're doing today, let's get right into it and talk about access to care. One of the first things the proposed rule comments on is that CMS does want to make it a bit easier for plans to use cheaper drugs on their formularies. In particular, they are looking at what are called biosimilar drugs, and you probably heard a lot about those in the news lately. What one of the rules does is to make it easier to use interchangeable drugs. So if a competitor comes out with a drug that looks, sounds, acts, feels like a drug that's already on the formulary, it'll be easier now for carriers to put that drug on their formulary and to notify beneficiaries 30 days ahead of time. So hopefully, as part of the overall administration's push to cut drug prices and address those, make things a bit easier for your beneficiaries. So potentially some good news for you there, or your beneficiaries there, to be more precise. There's also a new thing that kind of started this year in this plan year, where CMS did promote access to behavioral care. They allowed some specialties that you see listed on your screen to bill kind of under a supervising authority or a supervising physician. But now things like marriage and family therapists, mental health counselors, addiction and drug counselors would all be covered under Medicare Part B and be able to be billed as a specialty, which means that your clients could go get mental health care, see a marriage and family therapist, and have that billed appropriately. Same with any of the other counselors or addiction or drug counselors. And that's really a good boon to them, right? Especially in the midst of the opioid epidemic and all the other mental health issues facing our country here at the moment. It's a pretty easy win for a lot of your folks. The other thing that needs some attention here as we talk about access to care is utilization management updates, which is a long and fancy way to say prior authorization. But the language you'll see in the CMS rule is utilization management updates. So I wanted to make sure that was in front of you here. So what CMS is proposing to require plans to do is to dig into all their prior authorization, both their approvals and denials, and publish a report on that available on their website and submit that same report to the government for review. You see there on the back end of that the report will focus on populations with risk factors. So the CMS is really interested in knowing how prior authorizations are affecting those who are dual eligible or those who receive low-income subsidy for their Part D. And they also want to look at anyone with a disability, right? Our plans providing prior authorization denials or care denials or claim denials more frequently to those populations than they are in other populations. And of course, as I said a few moments ago, they want to ask carriers to make that information publicly available on their websites, easily searchable and behind no barriers to a login, or behind no barriers so you can't log in to see it, to be more precise. Lots of transparency there, right? And prior authorizations have been big in the news lately. Lots of doctors, lots of provider groups coming out against them. Some carriers like United Healthcare and others reducing their prior authorization or the number of codes that require prior authorization. So this is a hot button topic, but on the whole, this move should make it a little bit more transparent about what carriers are and aren't doing in the Medicare Advantage space, and maybe put some public pressure on them to make care a bit easier to access. The other thing that's happening here in the access to care arena here is giving Medicare Advantage enrollees access to the same sort of appeals process that original Medicare enrollees, when the decision is made to terminate coverage or terminate services in a, not a SNF, but a SNF that should be a skilled nursing facility, outpatient rehab, or by a home health agency. So in other words, if you have a client on original Medicare, they're on a Medicare supplement plan here at the moment, and they are using that Medicare supplement coverage in their skilled nursing facility or in their outpatient rehab, there is currently one set of appeals process, which goes well, I'm not going to say fairly quickly, but it functions one way, right? And while Medicare Advantage enrollees don't have access to that system, right? They're at the mercy of the plan. What this proposal does is to kind of take the plan out of the review of those claims and have a Medicare review that termination of coverage. And the other key thing the proposal does is in the current state, when someone is discharged from a facility, they lose their appeal rights. So Medicare Advantage enrollees in particular lose their appeal rights for these sorts of claims, right? They can't say, but I need these services. The carrier's decision is final. What this approval would do, or what this proposal would do, is make sure those appeal rights extend to when they leave the facility as well. So they'd have a reasonable amount of time to have that coverage reinstated when they leave the facility. So that could be a good win for folks who spend some time in those places. So right off the bat, that's kind of some of the ways CMS wants to improve access to care. I want to hear from you for a little bit. Just put some words in the chat here. How could these changes impact your clients, or what do you see as a win for your folks as you prepare to talk to them, already about their plans next year? Go ahead and type in the chat for a minute. And Chelsea, I'd love to hear anything you have to add on that as well.
Well, we know that I love giving my opinion out on things. So what I'm hearing here, overall, I don't want to speak exactly to any specific things, but what I think I'm hearing overall is that the federal government is kind of taking a look at all those Medicare Advantage plans, right? That we have been doing a big portion of our sales, and if we are someone who is selling in the Medicare space, right? And it's looking like between those prior auths and those like the mental health avenues to bolster the access that we have to mental health care, it looks like that's where the focus is kind of leaning towards, right? And the utilization of those management procedures. I think all those things together is kind of seeing that the overall theme is that I think that we, or the federal government, I should say, is really giving the side eye to those Medicare Advantage plans. I've been noticing a lot in my research for what I do for my job is the hospitals in general tend to are looking to kind of give less leeway to the Medicare Advantage plans when it comes to those prior auths, and just kind of stopping business with them completely in some aspects because of how often they're getting those prior auths denied. And I can totally see where hospitals could be upset by those things. So I think the government's starting to notice that as well and wants to step in and kind of say, hey, what can we do to better this process? So for me, if I was an agent, I'd be taking it as, okay, it looks like there's going to be some changes in the Medicare Advantage space coming up, not only this year, but in future years, especially with those, that evidence of, they're going to be putting out there with the research that they're doing with those Medicare Advantage plans. So it's going to be interesting to see what they come up with.
Yeah, absolutely. And I did see some emojis come in, actually some thumbs ups come in when we were talking over here on the first slide about biosimilars, making it easier to use that. So that's clearly something that you guys, our agent population appreciated. And again, there's the prior auth. There's lots of celebration around that coming in the chat as well. Next area is supplemental benefits, and that's another area that's coming under scrutiny here from CMS. In short, what I'm going to say over the next two slides is that CMS wants to make sure that all the supplemental benefits that Medicare Advantage plans are advertising, like dental, vision, hearing, meal delivery, all those sorts of things, they want to make sure beneficiaries are actually using them, and those benefits aren't just offered as a marketing ploy. So two prongs to this sort of regulation. First one is that plans are being required to submit proof that SSBCIs have a reasonable expectation of improving health with those with chronic conditions. So in other words, if you are making eligibility for some of those extra benefits contingent upon whether someone has a heart condition or high cholesterol or diabetes or so on and so forth, if you're going to provide those value-added benefits, there has to be proof that what you're offering, empirical, clinical proof that what you're offering will actually treat that condition, or at least make it better for them. They also want to make carriers report instances of SSBCI denials as opposed to the current state where they only report approvals. So CMS really wants to dig into, wait a minute, why are you denying these benefits that you're advertising to people? As they go forward. So your beneficiaries could have more access to those going forward here as a result of this rule. The other thing we want to be aware of here as relates to all supplemental benefits, so not just SSBCIs, but every supplemental benefit like dental, like vision, like post-meal discharge, so on and so forth. At the 6-month mark of the year, so if you're doing your mental math in June, plans are going to be required to notify enrollees of any benefits they haven't used during the first 6 months of the year. So your carriers are going to be required to send a letter to the beneficiary saying, hey, we offer your complimentary dental exam, your comprehensive vision exam, those sorts of things, and you haven't used them yet. What gives? As a way to bring those benefits front and center for your beneficiaries, and a way to encourage them to use them, and again, not leave those benefits as a marketing ploy. So I know there's probably a few enterprising agents out there. What might that last part, that notification about benefits, how could that change your off-season outreach and when and where you talk to your clients about benefits, or where you check in through them mid-year? Go ahead and put some thinking in the chat. Chelsea, happy to hear from you as well. And I want to see what you guys are saying here in the chat bubbles too.
Like I was typing in the chat already, I'll just say it out loud too. In my personal life, at least, when I talk to seniors, back when my grandma was still here with us, and I would go visit her in the nursing home, and I would talk to her friends at the dinner table when I would have dinner with her in her nursing home. So many of them would talk about, especially once they found out I worked in health insurance, would talk about how they were just so confused by their plan and they weren't sure what was right for them and what wasn't right for them. I love that it is going to now be a requirement to remind those of us, those seniors who weren't using their benefits, to then use those benefits. And I love, like Randy said, this is now a great time to reassess when you do those, like those revisits with your clients, to say, hey, did you get an email about, or did you get contacted about that dental exam money? You didn't. Oh, that's because your plan doesn't have it. Let's, if you wanted that, we can look at that for next year, or we can look at that for a change for you. I think that's a really great option, not only for the people who are being serviced by those plans, but us as agents, as we look to sell something that works best for our clients.
Absolutely, and certainly to reinforce the benefits of the plan, you put that they chose for that year, right? If they're not using some of the benefits available to them, you can absolutely put them back in front of them. Christine, I see your comment, and I agree in a lot of ways. There's lots of bells and whistles on those $0 plans, right? But the MOOP on those gets higher and higher and higher to offset the the actuarial value of that $0 plan and the zero copays and so on and so forth. And those bells and whistles kind of turn it less from a health insurance plan into something else, and sometimes. So a good point and a fair criticism of the industry that we're in here at the moment, but something to be aware of. Want to spend some time with what's going on in the D-SNP market here as well. Before we take a gander at what you're probably most interested in here is agent broker compensation. So let's talk about SEPs available for D-SNPs. The current state is once a quarter, your dual eligible beneficiaries can move to a different D-SNP if that's not moving, if the current D-SNP isn't meeting their needs. Same for their PDPs, right? If they happen to be a MedSup and PDP enrollee, they could change their PDP once a quarter if that D-SNP isn't currently meeting their needs. What CMS is proposing to do is to eliminate that quarterly SEP, right, where they can change D-SNPs, and change that to a once a month SEP for either their PDPs, if that's the route they go, or for D-SNPs. In relation to that, what they also want to do is limit enrollment in some D-SNPs to members who are also in a Medicare Advantage care organization administered by the same carrier. So in other words, if Priority Health happens to be your the MCO, right? The person who is administering Medicaid on behalf of the state, or not the person, but the carrier administering Medicaid on behalf of the state for that particular beneficiary. They may limit them from enrolling in other D-SNPs to try and keep them with one carrier for both their Medicaid and Medicare coverage. And the idea is that that would enhance coordination of care, right, between the MCO, the Medicaid branch, and the D-SNP, the Medicare Advantage branch, to hopefully give everyone a little bit more holistic view of how that client might be faring and what treatment they might need. So take that as you will. I definitely see the intention there. But of course, we're all in the business of finding the best fitting plan for our clients. And that sort of forced choice may not always be the right choice for your client. So certainly something to think about as you go forward. Also looking forward to 2026 is they're going to limit the out-of-network cost share on your D-SNP PPOs. Most D-SNP PPOs, their out-of-network cost share is the same as the in-network cost share. They have it at $0, but there are a few ones out there that do charge your members extra when they go seek care out of that PPO network or out of that established network. There's a laundry list of services that they're going to narrow that down forward, and they're going to make only certain services eligible for that out-of-network cost share. But in general, your D-SNP clients should see reduced cost share when they go to an out-of-network doctor. The other phenomenon CMS is targeting here is what they call D-SNP lookalikes. And what these are pretty benefit-rich $0 plans. But in particular, CMS defines them as plans that are not a D-SNP, but their enrollment is 80% or more of dual eligibles. So 80% of the people in that plan qualify for both Medicare and Medicaid. CMS is taking a long, hard look at that and saying, we'd rather, the more appropriate choice for those people is likely a D-SNP plan, right? That way they can take advantage of low-income subsidies for the prescription drugs and so on and so forth. So what they're doing is, instead of that 80% threshold I mentioned that a few moments ago, they're going to slowly lower that threshold over the next few years. They're going to drop that to 70% next year and 60% the year after. And appropriately discipline, I guess, for lack of a better word, those plans who are trying to look like D-SNPs without being D-SNPs. So there's some more scrutiny to come in that market there as well. So want to hear from you here as well and check in on some other chats that have come in. In what ways might those proposals impact the D-SNP market? And Chelsea, anything you have to offer here as well?
I just want to shamelessly plug, as we know I do, if you are interested in learning a little bit more about SNPs, whether it be D-SNPs or the C-SNPs that are now offered by our new carrier partner, we do have a SNP webinar coming up on the 24th of January. So if you are interested in that, the 17th of January, excuse me. If you are interested in that, you can go ahead over to our training calendar and register for that webinar as well. Love it and hope to see you there.
All right, thanks for the shameless plug. We have no shame here at Action Benefits. Thanks for that plug. We'll be teaming up on that one as well. In the closing minutes, we have 45 minutes scheduled here today. Probably only going to run you to about 10:35 or so, leaving you some extra time for questions here at the end. Let's talk about agent and broker compensation. You've seen NABIP comment on this. You've seen other folks comment on this. I want to try and give you the most objective summary of what they're doing here as I can. But first, before we give you the objective summary, I want to give you right here what you see on your screen is a little snip from the proposed rule, giving you some background of what CMS thinks they're seeing in the market, and what they think they're seeing in the market governs the three proposals that we're going to talk about in the next few slides. So in case that's too small for you to read, section blah, blah, blah of the Act requires that CMS develop guidelines to ensure compensation to agents and brokers creates incentives to enroll individuals in MA plans that are intended to best meet their healthcare needs. To that end, for many years, CMS has set upper limits on the amount of compensation agents and brokers can receive for enrolling Medicare beneficiaries into MA and PDP plans. We have learned, however, that many MA and PDP plans, as well as third-party entities with which they contract, such as field marketing organizations or FMOs, have structured payments to agents and brokers that have the effect of circumventing compensation caps. We note that these additional payments appear to be increasing. And then they go on to tell you what they're proposing and what they want to do about that. So I want to sit with that for a moment here and sit with this text. They are seeing some less than savory characters out there, right? Less than savory FMOs who are promising the moon and stars to agents, promising payments that go over and above the CMS defined compensation cap. And they're taking a long, hard look at that from a compliance standpoint. And here's what they're doing with the three rules or three unique proposals to address that and to level the playing field, so to speak, as in their eyes, at least, as we present plans to beneficiaries. So here's the first thing to think about. Many, but not all of our carriers paid the full CMS maximum for the fair market value for that year. But what CMS thinks and what they think they're seeing in the market is that if you have the choice between presenting a plan that pays maximum commission versus a plan that doesn't pay maximum commission, they think you're tipping the scales over to the higher paying plan, the one that's better for your pocket, even if it's not the best fit for the beneficiary. I know that's not the case because I know many of you, and I've talked to many of you several times here. I know you all do right by your clients, but that's what the rule says, right? That's what the documentation says. Don't shoot the messenger here. So what CMS is proposing then is to keep things fair. CMS is going to require all Medicare Advantage plans, regardless of size, regardless of location, to pay all Medicare Advantage commissions at the same commission rate, and we'd see a bump next year to $642 per first year enrollment. Also to note is that commissions that you get paid through an FMO would also be subject to that rate. So here at Action, we, you get directly paid from the carriers. We don't ever touch your commission money. There are FMOs that pay agents. There's that pass-through process. Those would also be subject to the $642 rate and other rates here. So the good news is, right, because we never touch that commission money, There's nothing about your relationship with Action Benefits would change under this proposal. You're always paid as earned directly by your carriers in this market. And especially with this increased scrutiny, right? It's not something we're ever going to get into, right? We're going to let whatever you earn from the carriers be between you and the carriers. And we know we partner with carriers that follow the rules here. So nothing at risk on that end. The second thing, and this might raise a few more eyebrows, is CMS looks at compensation in two discrete lanes. They have commission payments, which we just talked about, that $642 cap, and administrative payments. These are things like any payments you get for a health risk assessment or any reimbursement that a carrier might provide to you for traveling somewhere to conduct enrollments or so on and so forth. And those programs are a little bit rarer, but they're out there, right? And some carriers, in CMS's eyes, are using them to get around that compensation cap. So what CMS is really looking at is these administrative fees. They see them as a way for both carriers and FMOs to get around the law, to get around that compensation cap. For example, in the rule, they call out that some carriers for health reimbursement, or not health reimbursement accounts, health risk assessments can pay up to $125 per HRA, right? And looking at what that actually would cost another professional to do, they see the value of that service is actually closer to $12.50 for the hour worth of work it might take to sit with your beneficiary and do that. So they're targeting that. They're saying some folks, carriers might be overpaying for that service, at least in their eyes. They're also taking a look at payments that you might get for training and testing. And they're looking at those payments and seeing, at least in a macro scale, right, that those payments are growing at a really high pace, which suggests to CMS that those payments may be used to, or may be being used to get around the cap here as well. So in short, all those kind of extra payments, training payments, training reimbursements, those sorts of things are cut out, and instead there's only one line item which agents might be paid under, and that is that commissions payment capped at that $642 per year that we talked about on the last slide. So extra payments for HRAs, everything else are on the chopping block here under this portion of the proposed rule. The last thing to think about here is CMS is also taking a long, hard look at the contracts between carriers and FMOs like us, like Integrity, like other local people whose names I won't drop here. But they're taking a look at those organizations. They're taking a look at those contracts, and they're really investigating whether there's any parts of those contracts that unintentionally or would cause you or cause agents or brokers to steer beneficiaries into an ill-fitting plan. So in particular, there's four things they call out in the rule. When they look at renewing contracts between carriers and FMOs, the renewal of that contract can no longer be dependent on a certain percentage of that FMO's book being written with a certain carrier. So in other words, we might have enrollment targets, right? But we can't say there is that 30% of our book has to be this color by the end of the year or so on and so forth. That's not okay under the proposed rule. Likely they could not say 30% of your book has to be a certain color by the end of the year as well. Another thing to point out here that would be outlawed is our reimbursement of you for marketing activities if we tie that reimbursement to enrollment quotas. Fortunately, we don't tie that to enrollment quotas, right? All of our programs are available to all of our agent partners. The program you may have heard about a few weeks ago at the end of AEP is available to all of our agent partners, regardless of enrollment. But again, we can't say if you sell this amount of X carrier, we're going to give you marketing dollars for that carrier. It's got to be, at least in our current interpretation of the rule here, equal for everyone here. They also call out here in the rule either implicit or explicit pass-throughs where compensation flows through the FMO directly to the broker based on enrollment volumes. So an FMO, I'm not calling out anyone particular in our market, but an FMO could not share override based on enrollment volumes here, right? So they can't say if you hit X amount of enrollments, we're going to give you, an extra 0.5% or something. They're taking a real hard look at compensating above the CMS max here. And there also can't be, from an FMO perspective, we or the carriers can't provide you leads based on enrolling beneficiaries in a specific plan. So we can't, for example, set targets like if you enroll 50 beneficiaries in X with X carrier, we're going to give you more leads for that carrier. That kind of behavior gets targeted here in the FMO carrier relationship. But the good news here, again, is that if this portion of the rule becomes a reality, your connection with action does stay rock solid because we've always done things the right way here. Our programs, again, have always been available to our agent partners, regardless of your production numbers or which carriers you partner with, right? We just want you to do right by your clients, just as we have for the past 37 years. But I do want to let you know, again, if you work with FMOs or maybe you have friends that work with other FMOs who may be using some of those contract terms, that they may find themselves on the wrong side of the rules in 2025. I want to take some time out with you for you here. I want to see what you see as some of the largest implications of the changes we've just talked about here, talking about dollars going into your pockets and services provided to you. What do you see as some of the largest implications of that change? And while you're typing on that, I'm going to switch screens for a moment because there's something else I want to show you here in our last few minutes here together.
Randy, as you're switching screens, I'll say really quick, I think it's kind of interesting to listen to this proposed rule about that commissions being paid out or any sort of like goals set by the FMO that kick back any sort of dollars that are separate from those commissions, because I'm noticing as someone who talks to a lot of agents who left Action Benefits, moved on from them, explored other options, we'll call it, and came back to us, right? It seems that the wiser agents are learning that that amount of commission ends up coming out in the wash either way. So it's funny that the laws are kind of following up on what some of the more seasoned agents, the wiser agents, are learning on their own. So it's interesting how that's working out, but I guess it's great that we're going to kind of see how that might play out in the future if that other agents are agreeing with them.
Yeah, absolutely. Last thing I want to show you here today is I promised I wanted to give you an opportunity to see how you can leave your comment here and leave your voice, have CMS hear your voice on these rules as around anything you might be interested in, including agent and broker conversation or compensation. Chelsea's going to put this link in the chat for you, but I do want to show you a few things about the comment process here. She's going to put that, or she did put that link there. Thank you, Chelsea. And I want to show you where that link would take you. You'd be brought to regulations.gov, where CMS and every other government agency does have to post all their rules for public comment. And CMS and every other government agency is legally obligated to read and respond to every comment that is posted on a regulation. You can see where I'm going with this. So here we have the Medicare rule. This upper left comment button is where what you would use to submit your own voice here. You could also share links directly to this page if you so choose, or tweet about it if you like, or email it, or share it right on Facebook. But the entire text of the rule that we've talked about here today is here for your review. There's also CMS contacts you might go to. And you can see that only 117 comments have been left on this rule so far. So, ladies and gentlemen, there's about 50 of you or some out of here in the room. If each of you left a comment telling CMS of what you thought about the upcoming proposed rule and what you thought about what's happening in 2024, or for plan year 2025 rather, there's power in numbers, right? There's something you can do about that. There's a lot of opportunity to get your voice heard, put your voice out there, and tell CMS exactly what you think about some of these rules as they go forward. Commenting is easy as clicking on the link that Chelsea put in the chat, hitting that comment button, and then you're off to a text box where you can start typing, leaving a category. If there's any files you want to attach in support of that, you have the ability to do that too. And they'll ask you whether you're an individual, organization, or whether you're leaving an anonymous comment. And then you'll be asked to prove you're not a robot, which you're not. So fairly simple process, but I know it's an underused site, not underused tool, by seeing that only 117 people in the entire country have submitted comment here, right? But again, want to give that power to you, put that power, let you amplify your voice as you talk to CMS and kind of dictate, or at least help to inform the future of your profession going forward. All that said, want to thank you for your time and attention here today. That's, as I said, I have about 35 minutes for you here. Which means we've got some extra time for some questions and answers before the second part of our doubleheader dealing with marketplace rules. I want to give to Chelsea for any closing thoughts she might have, and open it up to our agents for any questions they might have.
I just want to say thank you so much for your attendance today. I saw some familiar names in the participants list today. So thank you very much. Just seconding what Randy's saying here too as well, that if you do feel like you want to have your voice heard and you would like to be part of the movement of any changes that you might want to see within the proposed rules or any future rules, leave a comment there. I do want to remind you that the cutoff date for those comments is January 5th. So if you do feel like you really want to leave one of those comments, make sure you do so before that January 5th date so that your comment is heard. And I look forward to talking to some of you again in a few minutes when we do the second half of our doubleheader.
Yeah, that's right. Just in case you haven't heard it, right at 11 o'clock. So in 24 minutes, we'll be talking about what CMS is proposing for the marketplace. Don't worry, not impacting your wallets as much, but if you got nothing going on, come see us in a few minutes, and we'll tell you about what CMS is proposing in your under 65 business next year. Want to thank you all again for your time and attention here today. Thank you, Christine. Thank you, Edward, for the kind words. I love spending time and educating our agents about what's going on in the business here. David, we can give you a link to our training calendar. Chelsea, if you would pull that, please, so Dave can register for that. And we can go ahead and you can sign up for that there. All that said, we'll stick around for a few minutes for any questions you might have or any other comments you want to add, or if you want to know more about the comment process or anything else, we are happy to oblige. We'll keep the room open for just a few more minutes while Chelsea puts the link in there, and we'll go forward. Seeing that there's nothing waiting here for us, we're going to go ahead and catch our breath, take a sip of water before the next session. But please reach out to us at learning@actionbenefits.com or reach out to anyone on our team